Ready when you are.
Oh, Brad's here too. Yeah, all right, ladies and gentlemen, we'll get started. Good evening on this June 17th. This is the June 17th REMAC meeting, and we are going to begin with. Better?
Yes.
Okay. We are going to begin with a roll call attendance. So I'm going to pass this over to Michelle.
When I call your name, please say present. Joseph Shaker.
Present.
Michael Batch. Robert Ackerman. Laura Avicoli. Stuart Kessler.
Laura's here. We'll come back.
Kelly Gorman. Kevin Manjal. Cindy Basilios. Grace Cacciola. Here. Dario Gonzalez.
Here.
Glenna Seda.
Here.
Bradley Kaufman.
Here.
Nathan Rice.
Here.
Donald Alive.
Here.
Doug Isaacs. Oscar Municita will be filling in for Doug Isaacs tonight. Kevin Ward. Anne-Marie Turgenti. Andrew Dahl. Allison Burke. Jeffrey Raybridge.
Present.
Reed Caldwell.
Here.
Bill Redliner.
Present.
David Benelli. Christine Chen. Mary Foote. Mark Kennedy. Eric. Jessica Fogle. Jessica Borges. Benjamin Zabar.
Here.
Kathy Harris. Mark Hanna. Robert Ruby.
Here.
Arthur Cooper.
Here.
Nick Langston.
Thank you, everybody, for being here. We the attendance. We're going to begin with the minutes from the April 8th meeting. Are there any questions about those minutes? Hearing none, do I have a motion to approve those minutes? Anyone? Okay, Dr. Krupe, second, thank you. Okay, so these minutes are approved, and we will move on. I'm going to go through the correspondence report right now. Stuff that I will just read. Just for understanding of how this works, there are a few positions that are being filled by their position. For example, the position that's going to replace Dr. Alexandra will be read into the minutes now. Those have to be read into the minutes at the REMSCO meeting before those positions can move. So they'll be read in now. They're appointments, they're not votes, but they will be read in here. They'll be read at REMSCO, and then at the next meeting, those positions will be eligible to vote. So I'm gonna go through this. So first, we had on the membership side, on April 11th, Andrew Ford, Vice President of Clinical Services and Operations at Deer Health and Hospital, submitted a request for Dr. Kara Hubman to be the alternate for Dr. I think Dr. Hubman here. Dr. Hubman, come, and like I said, is going to be forwarded to. On April 14th, Ken Rasky, President of Greater New York Hospital Association, submitted a letter designating Dr. Laura Kosterko as a physician representative alternate seat, primary seat, as an online medical control. On May 24th, Dr. Seda sent Chief Medical Director of the Y submitted Christopher Cusack's CV to replace Dr. Alexander. Again, this will REMSCO and live for the next meeting. There is a that we will have for the seat for the community physician seat. Dr. Vega and Dr. Hoke. I will allow them to get to the vote, which will be at the end of the. So yeah, because Lauren has. There's a policy that was sent out 25% independent continuing education recertification. I believe this was sent out via email yesterday or today. I give everybody the opportunity to review it. This is a policy statement, and it is on the New York State website as well. Okay, enforcement items, Evan Torres from New York, 498621 is suspended for 3 years, effective 6/17/25 for violations of Part 800. Suspension is stayed pending no further patient abuse violations during 3-year probationary period, and he is assessed a $2,000 penalty. Sorry, I'm. Muntakwa Sakar from Queens Village, New York, 519343 is suspended for 3 years, effective 6/17/25 for violations of Part 800. The suspension is stayed pending no further patient abuse violations during the 3-year probationary period. Assessed a $200,000 penalty. Jasmine Garth of Newburgh, New York, 472835 is surrendered effective 5/14/25 for violations of Part 800. Nathan Berg of Brooklyn, New York, 435230 is revoked effective 5/13/2025, also for violations of Part 800, and he was assessed a civil penalty of $2,000. Mark Dalton of Canton, New York, 307321, suspended for 1 year effective 4/23/2025 for violations of Part 800. The suspension is stayed pending no further violations of Article 30 or Part 800 for a period of 3 years, assessed a civil penalty of $1,000. Wow, that's a lot of reading. Daniel Howard of Patterson, New Jersey, 440655 is suspended for 3 years, effective 4/21/25 for violations of Part 800. Suspension is stayed pending no further patient abuse violations during 3-year probationary period, assessed a civil penalty of $2,000. Timothy McCabe from Attica, New York, 471857 is revoked effective 4/18/25 for violations of Part 800. Mark Jeffries of Jamaica, New York, 399153 is suspended for 1 year effective 4/1/25 for violations of Part 800. The suspension is stayed pending no further violations of Article 30 or Part 800 during the 3-year probationary period, assessed a $500 penalty. And these all can be viewed on the New York State EMS website. Okay, that was a lot. A lot of people getting suspended and all kinds of problems. Okay. We also got a correspondence from Chief Cacciola to appoint Deputy Chief Evan Suchecki as her alternate. Is that correct? Great. So that, again, will be read into REMSCO, and we will move forward with that after that. Okay, this we read. This we read. This one we read. Okay. I believe that is our correspondence. Are there any questions about the correspondence? Please don't make me read anything again. Right? Exactly. Okay. Next is the Executive Committee report. The Executive Committee has not met since the last meeting, so I will move forward to subcommittee reports, and we will begin out of order with Dr. Kosterko and QA. Lauren. Okay, she put tomato in her mouth. Give her a second. You want to go to medical standards and we'll come back? All right, we're good.
Oh, there you go.
All right, now it's off.
Just turned it off.
You just turned it off. Now push and hold it.
I like
There
to
you
hear
go.
when it's on.
Sound okay?
I don't know. We can't hear you. Only Chris, only
Charlie.
Charlie can.
Can you hear me, Charlie? Okay. The Quality Committee met May 21st virtually. Here are the takeaways from that meeting. First, research and data requests. The Quality Committee was previously tasked with reviewing requests for regional involvement in research projects, including support and dissemination of related information. We're currently discussing how to create a more standardized approach to do this. So we revisited a previously drafted policy that outlined a standardization review process. After discussion, the policy was formally approved and will be submitted to the REMAC for final approval. Additionally, we plan to develop an electronic submission form to streamline and manage external survey requests more efficiently. New York City CARES Registry. So we're continuing to try to support CARES involvement in the region. We have identified some challenges to participating. One is that we've learned that Sansio charges a $2,000 annual fee for data integration, which could be or create financial hurdles for some agencies. Another issue we identified is due to the state removing the process for data validation, the data has become somewhat messy and requires some manual chart review, which increases staffing burdens. We'll be reaching out to the data manager for the state to address this. Several agencies are in the early stages of participation and are assessing the time and personnel needed to participate in CARES. A representative from Northwell, who's heavily involved, has agreed to speak to us at an upcoming meeting about the level of staff involvement and bandwidth required. For the First Watch regional dashboard, we've been continuing to review the First Watch regional dashboard and identify opportunities for improvement. A team from our committee met with First Watch personnel to discuss some of the areas that we identified for improvement, and adjustments are currently being made to the dashboard. So please continue to let us know if you notice any discrepancies between the regional dashboard and your own agency's data, so we can continue to improve it. Regional First Watch training webinar was held on June 12th. If you weren't able to attend, we did record it, so please look out for an email to that link so that you can watch if you need any help with accessing the platform. We, exciting news, have a summer quality intern joining us that will be starting July 7th, who will be supporting data analysis and continue some of the ongoing quality projects. This will include further analysis of our intubation data based on feedback we received from previously presented data with intubation and standing order sedation. BLS iGel. Based on encouraging findings from the Hudson Valley pilot study, there's a strong possibility that BLS iGel use will be approved statewide. Our committee's begun preliminary discussions to prepare for potential regional implementation, exploring collaboration with training and ed, some quality performance review processes, and maybe identifying some grant opportunities to support equipment acquisition. Lastly, it's been proposed by some members that our committee perform quality review of data, metrics, or any relevant cases related to the recent FDNY patient transport destination policy. This issue remains under active discussion within the committee. Our next meeting will be held virtually on June 20th at 1 p.m.
Any questions for Dr. Kosterko? Okay. We're going to discuss the tag for this patient destination a little later. We'll discuss the QA component as part of that discussion, so I'm not going to burden it now. Anything else, Lon? Okay, great. Thank you. Dr. Benelli, medical standards.
Can you give me a code? No? It's on.
Just move it closer to your mouth, Dave. David, like this. Speak into the microphone. Closer. Thank you. Much better.
Okay, so for lack of discussion topics, the Medical Standards Committee did not meet. There was no input from protocol, no from CNC. There were no unfinished business items, no new business items. Therefore, out of respect of the members' times, we did not meet. Thank you very much. That's the end of the committee report. There will be shortly dates for the new academic year. Michelle just sent them around.
Okay.
And we wish everyone a happy summer.
Thank you.
It's a virtual meeting, people would show.
It was virtual. That's true. That's a good point. Okay, thank you. Any questions for Dr. Benelli? Okay, hearing none, we'll move on to CNC, Dr. Barbara.
The Cranston Committee met due to the meeting in May. Close to the mic.
Put it next to your computer. Not on you. You gonna do it right?
Due to the meeting in May, having difficulties with the REMAC servers being down, we opted not to. Can you hear me okay? Okay, thank you. I was very worried. There was no meeting in May. There are notes from the April 3rd meeting, which are residual. Joe has put up the final version of the revisions to the manual, which was distributed by Michelle earlier today. Again, version control was a little bit of an issue due to the OneDrive, Microsoft, Office Suite hack this week. So, unfortunately, there was a little bit of back and forth, but thankfully some people caught some errors and there were some issues with version control.
I have a question. Is it a typo or is it category B alternate source 36 hours maximum? Is that minimum in purple? Should that be minimum? Should that be minimum? Category B is 36 hours minimum, and then there's a synchronous minimum and asynchronous maximum, but isn't in purple, shouldn't that be minimum?
It's,
Well, I don't,
so that's, I think that's why it's maximum is you can only do towards your full 72 or full, I'm sorry, it's more, it's 72 plus 12,
That-
is 84.
Can
right?
I don't understand Dr. Zabar's interpretation of the math.
Where it says okay, in the purple line next to category B, it says alternative source, 36 hours maximum. Why does it say maximum instead of minimum? And the answer is because you can't, for your total 84 hours, the maximum amount that can be category B is 36.
Correct.
so there's no. Okay,
The rest has to be category A is what it's saying.
so, but I guess the question is, I know, okay, so but you need, if you have 18 hours of category B synchronous, the remainder to get to 84 could all be category A.
Is that what this is saying, minimum? It's supposed to be your 48 hours of category A and your 36 hours. Yes, can I clarify?
I think the operative preposition "and" signifies a need to complete both 48 and 36. Am I misinterpreting that?
I think in purple, it should be minimum. You need 48 hours of category A minimum,
I think-
36 hours of category B minimum, and then how you actually get that is in red.
So I think the clarification is because this dates back to when it was all one big pool of CME. And we broke it down into category A and category B. We should have made it clear that you must have at least so many of category A and so many of category B. But the way it's worded right now is you could theoretically do all of it as category A, but
No,
a
it just says
maximum
"and."
36 of category B.
You need 48 and 36.
Right, so then you don't have a maximum. That line is just
Minimum.
a remnant of the old.
I think that's the intent, I think what Paul's saying, that with that change, that's what that means. Okay, that makes sense.
But
"And."
yeah,
So that's a
Couldn't there-
typo.
could there
Yeah.
in theory someone who does all category A and still meets the requirement?
Not anymore. Now that says
Now we
36 hours
changed
minimum.
to that.
But why? That's a good question. I mean, why, if someone really wants to be over diligent and do all 84 hours category A, who am I to tell them not to do that?
Okay, so then the word maximum is correct.
No, so what?
Yeah, that was my interpretation.
That's how we voted.
Okay.
So I guess my question there is to what Dave's saying, if you interpret it that way, do you have to do the 18-hour synchronous minimum? Like, what does that mean? If you say you could do all 84 hours category A, then the 18 hours category B minimum
No,
synchronous.
I think it was correct the way it was, and
Yeah,
Okay.
minimum.
okay, so what it's saying is that if you really, and again, Nathan and David are correct, if you wanted to do all of your hours as physician directed call review, you could theoretically do 84 hours of category A, and that would work. According to what we, again, that's.
No,
What is 8?
No, Joe, it says A and B, 48 minimum and B. You can't do 48 of B.
And I-
48 hours minimum, 36 hours maximum. Joe Ranieri, please change the word back. That's the way we voted on it, and the interpretation was doing a combination of both.
Can I suggest that we remove the minimum and maximum and just write a comment on the bottom that if anyone wants to do category A, they can do it?
I prefer not to vote on this again. And if we want to take it back, we can bring it back for September.
So, okay, we're having a discussion right now. David, if you want to make a motion like that, you can. I don't know that we need to, but It's
I
up
mean,
to
if
you.
it's causing so much contention, whether it's
Just so
minimum or
everybody's
maximum.
aware, the way that this has been enforced since the time we started was that basically these two requirements were put as separate requirements.
Right.
You had your category A requirement and your category B requirement. It didn't matter if you had 100 hours of category A, you still had to have your category B requirements. That's how it's been enforced for
But that doesn't make
however
sense.
long I've been here.
Yeah.
Is that the intent to continue that, or this is a change?
You just-
Guys, can we have one conversation with the room? Joe is correct. This is a remnant from the old, when we initially put this into place and have A and B. Okay, so the answer is right now you have to do at least 48 hours of category A. I don't understand how the maximum really works if we're saying that you have to do both. Because if you have to do both, then you're saying you can't do 37 hours, right? Because it's a maximum. So I don't understand that term. It really should be at least 36 hours. And the minimum and the maximum for the synchronous and the asynchronous does make sense. It's basically saying that you can't do more than, I think that's 18 hours of asynchronous, meaning if you go and read, it has to be, at least part of it has to be synchronous.
And Joe,
So
that's
that part makes sense.
That's exactly what I was trying to say about the.
So the only thing that doesn't make sense is the word maximum. If we're saying that you have to do A and B, then you have to do at least 48 and at least 36. Correct? Does that make sense? I mean, maybe I'm wrong. If I'm wrong, please tell
We
me.
could change the words to at least,
No, I'm
might
just
make it
saying,
simpler.
is that
Yeah,
correct? 'Cause that's
that was
like-
the intent. And
That was the intent.
yeah, that was the intent.
Fine.
The idea of doing everything category A, functionally, I support it, but it wasn't what was brought up in April.
Okay.
So we're working on what was brought up in April.
Okay, so then really what we're talking about is a typographical error, that 36 max should be 36 minimum.
Yes.
Is that
was-
correct? And is
that's
everybody
fine.
okay with that? Can we move forward then?
Yeah.
All right. Are you okay with that, Paul? Okay. All right, so let's make that minimum. And I think we're all on the same page and we can move forward.
We've also been moving to the 4-year renewal pending for July 1st. So the recertification cycle will be implemented for all new REMAC certifications starting July 1st. Kevin is ready to launch that with the new classes. And that is basically that's it. That's all we have for our reports of what's active. Thank you for the feedback on the table, everybody. Thank you for helping us modify the manual to have it updated.
Okay, does anybody have any questions for Paul? Okay, hearing none, we will move on. Okay, Morty Lax is not here, so we are going to skip the training and education report. Yes, not Joe, Nathan, and Bill. Dr. Berkowitz, interfacility transport tag.
So we still waiting for feedback from the document. I believe it was sent to everyone here. So as soon as I get feedback, I can continue to modify the document, and then I think we probably can endorse the document. But I would like some feedback aside from the folks who participated in creating it.
Okay,
So Michelle, maybe we can send it out again. Appreciate it. Thank you.
okay, thank you. There was an RTAC meeting. Doug usually reports that, but he's not here. So I guess we'll pass that and we'll move on to the regional council update. I'm sorry. Oh, were you at the RTAC meeting?
Oh.
Okay, so let's move on to the regional council update. Dr. Krupe.
Okay, so regional council last met here April 22nd. Approved motions was approved to deem the Forest Hills DAC CON expansion application complete to go to public hearing. There was approval to authorize New York City REMSCO staff and executive committee to select and submit nominees for the New York State DOH EMS Mental Health Resiliency Officer Training Fellowship Program. A first responder mental health symposium was scheduled, now held on May 15th, 2025, in collaboration with the Queensborough Emergency Preparedness Coalition. Programming included QPR suicide prevention, credentialing, keynote speakers, and an EMS peer support panel. Okay, REMSCO is actually a co-sponsor, and thank you, Joe Ranieri, Michelle, and Georgette for all the support of that event. It was a very successful outing. In partnership with New York City OEM, the Regional Council is coordinating the distribution of up to 100 LifePak 15 cardiac monitors to volunteer ambulance services. Surveys will assess clinical equipment needs. The initiative is nearing final approval. The Regional Council, New York City DOH, are launching an updated infection control program in May. The program includes online modules, train-to-trainer sessions, and PPE distribution. The Health X initiative, supported by new grant funding, will allow EMS agencies to share pre-hospital care data with hospitals. Contract finalization is underway, with development to follow. EMS program agency contracts for the year 2024-2025 remain over 10 months overdue, with no explanation yet from New York State DOH. Regional Council is preparing to initiate legal proceedings. The Adams Committee report the following: new transfer operating authority applications. The Office of Regional Counsel received an application from Forest Hills Voluntary Animals Court for a determination of public need for expansion. The committee reviewed the application electronically prior to the meeting and found it to be complete. The volunteer assistance tag is assisting whites from the volunteer ambulance service, in requesting an administrative hearing to challenge the New York State Department of Health's recommendation to surrender its operating certificate. The recruitment and retention tag will conduct outreach to New York City public high schools with allied health programs to promote EMS career pathways, including roles in field response, operations management. A meeting with high school is already scheduled. Legislative submitted follow from the executive budget. He also submitted a separate letter recommending that any changes to Article 30 be made through the regular legislative process, not through budget legislation. They also continue to advocate for the renewal of EMS program agency funding contracts. A committee member reported that the Supreme Court of Schoharie County ruled the New York State Department of Health cannot discipline paramedics through administrative hearings, citing the Seventh Amendment right to a jury trial. And lastly, New York City REMSCO has preliminary approval for a $1 million grant to replace its radio communication system. The next regional council meeting is scheduled for next week on June 24th.
Great, thank you. Any questions for Dr. Krupe? Okay, get used to the smooth tunes of Dr. Krupe as he gives us the CMAC and SEMSCO update.
Okay, so this is a somewhat abbreviated report. I'll try to get through it as quickly as I can. It's still somewhat lengthy. Okay, and if I miss anything of importance, anyone who's there, please, let me know at the end. But CMAC SEMSCO last met on May 6th and May 7th. Approve CMAC SEMSCO motions, approve the removal of the adult-only limitation from the BLS supraglottic airway protocol, allowing agencies, if trained and equipped, to use supraglottic airways on pediatric patients. The protocol is effective July 1st with the protocol rollout. There's approval of the initiation of a regulatory process requiring ALS CMS agency medical directors to be approved by the regional REMAC as online medical physicians. There's approval to recommend to the Commission of Health a 10% increase in EMS education funding, a 15% increase in partner agency and REMSCO base funding, and a 6% annual cost of living adjustment, in subsequent years. Bureau report, there were contracts, all program agency and regional EMS council contracts have been executed. Education training, the committee is updating the outdated functional job descriptions for EMTs and AMTs. The committee is collaborating with program agencies and the Bureau of EMS and trauma systems to ensure consistent guidance for course sponsors. The finance committee reported out for year 2024-2025, approximately 8.5 billion of the 10.5 billion allocated to program agencies and regional MES councils has been spent to date. Several reasons for delays: application due to voucher timing and dual eligibility. The committee emphasized the need for improved submission tracking and regional awareness to avoid lapses in fund usage. Systems. For low intervention scenarios such as lift assist and welfare checks. The focus remains on clarifying what constitutes a patient under clinical, legal, and operational frameworks, with future guidance expected to impact protocols, QA/QI processes, and risk mitigation strategies. A particular need reform discussions respect to resume following finalization of the state budget. The Systems Committee anticipates future recommendations on streamlining the CON process, improving service area transparency, and addressing operational conflicts between agencies seeking to expand or update service zones. Regulations Committee, the Legislative Regulatory Affairs Committee, formerly known as the Legislative Committee, officially adopted this new name to reflect its dual role in tracking mess-related legislation, shaping regulatory policy in collaboration with New York State DOH, Bureau of EMS, and trauma systems. During the meeting, the committee reported that the final New York State budget did not include EMS Medicaid reimbursement increases, nor did it adopt Part R of the proposed comprehensive regulatory and overall package that has been under discussion in previous sessions. These omissions were noted as missed opportunities to improve EMS sustainability and reduce provider attrition, and the committee emphasized the need for continued advocacy from SEMSCO and regional stakeholders. A key focus of the committee remains the advancement of community paramedicine program in New York State. There's a statewide community paramedicine work group, which includes representation from multiple SEMSCO subcommittees. And that's nearing completion of a recommended implementation framework, which includes standards of medical oversight, data reporting, patient eligibility, and funding mechanisms. Next item was several regulatory packages are under internal review, or in the pre-publication phase. These include updates to ambulance vehicle standards, including stretcher safety, trauma system designation, and data requirements, blood product administration protocols for EMS services, and revised language for documentation of patient refusals and transport exceptions. Each regulation is expected to undergo stakeholder review before public comment opens up. Safety Committee is reviewing policy statement 00-13, which outlines EMS response to hazardous environments, to reflect current best practices and operational realities. It's also reviewing and updating patient restraint protocols. Quality metrics, the committee provided an update on the implementation of the Shematron 2025, which will go into effect on December 2nd, 2025. The updated validation rules will expand the logic of cardiac arrest performance measures, transport decision-making, improved data integrity checks. A new work group has been convened to review and streamline the EPCR impression procedure medication list, aiming to reduce redundancy and improve data utility. Innovations and Research Committee, the committee reported ongoing work to guide the responsible integration of artificial intelligence in EMS operations. The committee is drafting a white paper and best practice for AI use in EMS, focused on areas such as documentation systems, computer-aided dispatch, and quality assurance workflows. EMS for Children program, part of updates on pediatric care initiatives and federal funding advocacy. The New York State EMS Memorial was held on May 20th, and four of our Fidney brothers were honored. Anthony Cosino, Robert DeLeon, Mark Stevens, and Christopher Swarovski. Next upcoming meeting is actually December 9th, through 10th in 2025 in Troy, followed by December 9th and 10th also in Troy. And that's my summary report. I don't know if I, again, missed anything. Okay, you want to add, Michael, or anyone else?
Just two minor points. One is about the data integrity tag, which I think is an important thing for people to understand. There's problems with our data going to the state bridge, and there's a lot of details about how it flows that this committee in order to improve that ability. And again, the purpose is to enhance our ability to look at quality data, but when it doesn't go in, it doesn't make a difference. So that I think is one big thing. Just from the Innovations Committee, there are two innovations of research. One is that there's going to be, hopefully this will come out in the next few weeks, but a research pathway for people who are interested in doing research in New York State to be able to kind of pass it through an organized process. So that will be coming out. Then the AI and EMS subgroup or the work group it's really interesting. I mean, I think that it's it's coordinated with the New York State DOH AI. It's Empire AI Consortium. So hopefully EMS will be part of that discussion. The one thing I would just say for EMS and relevant currently is that a lot of people are using AI platforms to write their PCRs. And we haven't yet put out a statement about what that looks like and what the dangers are. But in general, it's wise to kind of think about what's the guidance for agencies to give to EMS organizations that because they're using there's a New York City focused AI generating PCR platform that people use. It's open. I don't know where it's stored, but it's something that if I think all paramedics and EMTs are probably So it's why to kind of about what's the guidance that we should give to our agencies around using that to protect patients' information and that type of thing. It's like, it's happening. So, I think that my take on it and my thing is that we should be, embracing AI, but in a safe way. And so if there's, where the platform is, how it's being used and how it's being generated. So, but I would advise folks to think about that in their own agencies. Thank you.
Yeah, I think Skynet will become self-aware in the next few months and things will change for us all. Okay, any other questions for Dr. Krupe? The only question I had is now that the state is approving this iGel, in terms of agencies in our region deciding to use it, we should have some process by which the agency at least informs us so that we can make FY aware, so that the region could be aware that these devices will be coming into the emergency room. Is any of that?
So the policy statement.
Okay.
And basically, an agency, it'll be in the BLS protocol, an agency can do it, but they're required to have appropriate training and equip and a sign off by the agency medical director that they've been trained. And that is supposed to be transmitted to the region to let a region know that, yes, we're going to be doing this and that we've done the appropriate training.
So once it's transmitted, they can go live right away? Do they have to get, does the region have to say, we understand, we approve, or not approve because it's already the state
Yeah.
protocol, but you can go live as of this day just so we're aware, or that's not included?
I think it's just the notification for awareness and that you agree that, yes, they've done the training and the medical director signed off on it.
Got it. All right, Ben?
Is it required that, I know they have to have capnography, but is it required that it's recording?
No, you're
Continuous.
required to have waveform capnography. The gold standard obviously is to be able to record it, but they did not make it a requirement that it has to be like recorded and stored, like a physical tracing of it, but you have to do continuous waveform.
Is that something we would want to consider for our region? I mean,
I don't know that you can do that for the region or not. I mean, we can certainly talk about it. I think, look, the intent of everyone at CMAC was, yes, that would be ideal. It was of technology, like the cost of devices that, because obviously if you have a full monitor, you can do that. But some of the other devices that are used for waveform capnography don't necessarily have a printing capability or a way to download that data for storage.
Yeah,
I have a problem with that because in the case of a QA issue where there's concern between the emergency compensation with high people group.
we'll help you.
Here now?
Yeah,
Yes.
good.
The issue way
Mhm.
is going on, whether or not the group was lost, was not fully inserted, and if there's a reasonable concern by the emergency company that this is not properly, how do we then justify or prove that in fact the crews were doing the right thing, or if they weren't doing the right?
Right.
And if we can't do that, then I don't know what the purpose of this.
Yeah, no, I think you're right. And I think
That's a
the
concern
question
we all-
is, can we as a region, and we may be able to kind of say that if you want to do it in this region, that you have to have that ability. I know the state didn't go that far, but maybe we can.
I mean, I think this state presents a minimal standard. We can ask for a higher standard. We can definitely vote as a group to require a higher standard. Would that be turned down by the state? Would somebody fight us on it? They might, but if we feel that that's what's needed for the safety of our patients, then we should make that motion and we should vote on it and send it along its way. So I think, I agree with you, Dario. I think that we do need to have some method by which we ensure that we're notified, we ensure that we know when these people are starting, and to appropriately QA these units. I think that what the state is saying, it's on the medical director to do that. As a region, we generally operate more unified than that, and I think that if that's something you want to move to say, we can make that motion.
Want a motion? I'll make the motion.
You have to.
No, we
Would be
need to
nice.
require
I'll second it.
All
Okay,
right.
what is the motion though? Let's be clear.
that we think these alternate devices, that waveform capnography is required and some sort of recording process of the waveform.
Okay,
for QA
For
purposes.
all supraglottic air replacements.
Superglottic, yeah.
Yeah.
correct.
Thank you.
Sure.
So I'm just gonna repeat this, I'm get you in a second, Ben, but just to make it clear for Michelle. So for all supraglottic airways in this region, waveform capnography with record capability is required.
Yes.
Okay. Go ahead.
I think the past, he put out an advisory from the REMAC about MCIs for supraglottics. In MCIs for supraglottics,
You gotta have to go closer to you.
it was allowed to not have recording in an MCI, but as soon as possible to have recording. So I wouldn't want to
We did not talk about before.
okay. I don't know if we need wait, no, sorry. The advisory that was put out was that because the idea was in an MCI, you may not have any capnography for supraglottics due to multiple patients. And so I wouldn't want to undo that. So I don't know if we would want to modify it to say, with the exception of an MCI, that same advisory. And so you need, for individual patients, for supraglottics, you need waveform capnography. And then an MCI, you may have not able to be, but you need to do as soon as possible.
Right, well, unless Dario, can Dario just accept it, or has to be a motion to amend? Can you do that? I mean, technically, so technically we should make a motion to amend. He did, he wanted a friendly.
I make a motion to amend.
Okay, so he makes a motion to amend, we need a second. Okay, so Brad seconds that motion to amend. Any discussion on amending the previous motion? The amendment would add the language, except in MCI situations. So that would be the only amendment. Paul?
Housekeeping perspective, is there anything else that might fall to this a different standard of care during a mass casualty situation where maybe perhaps we should have a care during an MCI document and add this capnography as part of that? Because there might be other things we might need to have a modified expectation on by the nature of being an MCI. There might be more than just capnography that's relevant during an MCI to have a modification on.
Altered
point. So I
standard of
think that-
care for that or like a pandemic or some other.
Right, so I do think that maybe at protocol, we should look at in general, for MCIs, what standards do we want to change if needed? So I think we should look at that as a whole. But for right now, the amended motion is as was read. Kevin? There you go. You're on. Just move it closer.
I'm in favor in spirit with the motion. I'm just curious for anyone that's running an ambulance day to day, are there any technical limitations to recording? Like is it available on every single platform? Is the data storage stuff
So-
routinely available?
The answer is it's not available on every platform. The units that a lot of these agencies are using are very simple units that just give you a number. They don't give you true waveform. If you want waveform with recording, it's generally a more expensive device. But that's what we're saying. It's discussion on the amendment. Yes. So the amendment is just about adding the MCR part.
And-
Right? Really, what we're having now is a discussion on the original motion. Why don't we vote on the amendment and then we will go forward from there. The amendment can be a hand vote, the final will not. So all in favor of the amendment to add the language, except in MCI situations, to the original motion, please raise your hand. I can't. I can't see anybody behind the pillar. Reed, anybody behind you with their hands up? 1, 2, 3, 4, 5, 6, 7, 8. 14, 15, 16, 17, 18, 19.
And Joe,
Anybody opposed? Anybody abstain? Okay,
and just for housekeeping reference, it's the REMAC advisory 2018-06 was the one
That's
we
what
have
we
about
had.
supraglottics and
MCI.
capnography and MCIs.
okay, so now we're back to the original motion, which is this device basically requires, so the motion now reads as follows. all supraglottic airways in the region, a waveform capnography with recording capabilities will be required except in MCI situations. That is the current motion on the table. Any discussion on that? Yes, John.
Just reviewing the data on this, which I have to refresh myself on right now. This wasn't part of the studies that kind of put iGel into the BLS armamentarium. In fact, I don't actually know of any study that has validated the recording of capnography is associated with improved outcomes. So, in the concept that are we throwing out the baby with the bathwater, given that from my understanding, although I'd appreciate to hear from my peers on the more operational level about the implementation challenges, assuming that this requires essentially moving from a small device to a full monitor, is my understanding of what that would mean. I wonder if we're actually imposing a significant burden without any evidence-based support for it. And I wonder if maybe it's a little bit much.
Okay. Anyone else want to comment? Ben and then Jeff.
I mean, I'm not against the iGel, but I'll just point out that I think upstate, a lot of people are in a different situation than we have here in the city. A lot of places were interested in this because BLS was running cardiac arrest and respiratory arrest for a long time where there was limited ALS. I think in the city, we're going to get this BLS iGel and then ALS is going to be sort of stuck with it. Because if it works, they're not going to pull it out. And I know there's arguments about whether intubations improve outcomes, but you're having this potentially less secure airway. And I think from a QI perspective, especially for the fire department and so on, like if we have BLS or we're putting these in and then there's, concerns about whether it's placed properly, we'd like to be able to ensure, so I think the system's a little different where we have ALS. And so BLS is going to be putting these airways in and then ALS is going to show up. And I think it's important that we be able to review those if there's issues.
So I just wanted to ask, so I'm looking at the actual language of the protocol now. It's supraglottic airway placement in cardiac arrest patients. And then parentheses, it says as regionally approved. So you absolutely can do this, make your own regional policy about capnography or whatever else you want.
I just want to ask a question. Dr. Vega, I know that Jamaica is doing iGel for BLS. Do you know what the price is of the unit that you have or a unit that does recording? It's significantly more expensive, right? Got it, okay. The unit you're using now just gives a number?
Yeah, we're trying to get multiple readings. When we get in-house in Jamaica, plus we have the examiner attest to the iGel placement. ALS doesn't want to sign off on it.
Okay. I just wanted to know what you were doing from a technical perspective. Nathan?
Maybe we should look into the answer to these questions before implementing this, because if it's so expensive that it's basically gonna mean you can't have BLS iGel in the area, we should at least know that before making a decision.
To that point, that is why at the state level, they didn't go as far as making that the rule because they were concerned about cost.
Okay. That's a very valid point, but let's keep going in discussion. Mike?
Yeah, so I was gonna say, if you do, in a quick search, there are devices that are in the 3,000 to 5,000 range that are available with recording capability. And so, I mean, again, it would be an investment. I think it's probably a wise investment for a safe airway. Again, but I think that we're in an environment that's different than upstate. And so I think we might have the luxury to be able to have an even safer opportunity. And again, I don't think that there's evidence that whether it's recorded or not makes a difference. But you want to have a reliable source of information when you're evaluating airways. So I think I would lean in that direction of supporting a recorded device.
Okay. Pam, and then Paul.
A quick question. So is this only allowing for BLS to do supraglottic airway for cardiac arrest
Correct.
patients?
They can only place it in cardiac arrest patients.
Paul?
So just a couple people had mentioned that, this is the city and that's upstate. We also have a similar conversation how overburdened the system is. And I would remind everyone that not every part of this city is an urban environment. And there are situations where delayed arrival. So if we're going to do this, there are reasons beyond our geography. We're not that discrepant from upstate, and we might have other issues getting to an ALS provider to a patient, such as vertical response time, traffic issues, et cetera, that the BLS crew might be on scene first for some time. And if they can put the device in safely, we should be engaging it, not leveraging our urbanism as something to hide behind.
Well, I think everybody agrees that getting an airway in these patients earlier and quicker, if appropriate, is good. But I think that the problem is that we want to make sure that it's done safely. And the only way to do that after the fact is if we have some recording of the airway being intact or the end-tidal CO2 being continuous for the duration of the insertion. So I think that I agree with you, Paul, but at the same time, we really do need to be able to monitor, right?
100%. Just a caveat to that, when we have BLS only units responding to cardiac arrest, we can't determine when a paramedic is getting there. And if
Correct.
and in a system where it's medic or EMT, those two providers might be waiting, and that patient might be suffering for an ALS provider to get there. The units were combined in a different situation. Maybe we could say every unit's a paramedic unit. But as we respond EMT only units, airway management should be paramount.
Agreed. John?
Yeah, I mean, just to be clear, I would expect many of these patients, the capnography is not going to be that helpful if they're in cardiac arrest and they've been in cardiac arrest for a while.
Right.
So like how much quality we're going to get out of that is going to be challenging, because are we really going to ever be able to look back and say, oh, gee, you didn't have any significant capnography. That means it was misplaced. I mean, I think that's really hard to make that assessment. And I think that unfortunately, it all comes back to training, and how well we train folks. And then on the quality side, I mean, honestly, like the only way you're really going to have an idea of what's going on, it's not going to be the monitor. It's going to be the person who reads the PCR, talks to the crew, and kind of reviews the case with them. That's where you're going to get a lot more actually impactful information. So I just don't know how much we're going to get out of it. But I do think that Paul's statement regarding BLS arriving early, I do think there's probably part of this decision we might want to look at what's the average time where the BLS arrives to an arrest before ALS, and understanding those issues so that we can actually, because those are if you said BLS frequently arrives, 10 minutes before ALS or 7 minutes before ALS, 3 minutes before ALS, this gives us an idea of what we're playing with in terms of making this decision. Again, I think that we just don't have the data to really endorse it. And I think it's important that if we're saying that we want to use recording as a barrier to entry, then I think we should actually just say, let's just not approve it if we think it's dangerous, and then be clear with our intent, as opposed to saying, we're going to make an extra barrier.
So, yeah, but we don't have the ability to refuse it. Well,
It says in parentheses.
okay.
Yeah,
Okay.
we can
decide not to approve it plainly.
right, exactly, which is fine too. I just think I'm saying, like, let's make the decision. If you're saying we're going to do it as a barrier to entry, they put this other thing in there, and we're not convinced it's going to help patients, then all we're doing is making people buy equipment that we don't actually think helps our patients.
Correct. Dr. Cooper.
Just as a minor technical point to follow up on John's discussion, looking at, average time or the average difference in response, in terms of how long it takes an ALS crew to get to the site of a BLS, unit. As you said before, John, we're likely to, in heavily, resourced parts of the city where the numbers of cardiac arrest are likely to be much greater, you're going to end up with a much lower average time than you might really expect, based upon pockets of areas where it's hard to get to. I would imagine that if you've got a BLS crew, that's dealing with a cardiac arrest at Breezy Point, it's a little bit different than a cardiac arrest, in Midtown Manhattan, right? So I'm not sure that, just looking at a straightforward average is going to help. I think the analysis has to be more nuanced than that. Really looking at some of these pockets where the potential delays are the longest. Thank you.
Thank you. Ben, Pam, and then we're going to wrap up this discussion and we'll go over the options right
Yeah.
now.
I mean, I think the state often seems to have a fairly low bar when they approve things, like similar to CPAP, where they did a few people and it seemed like it went okay. And so the way to flip this around would be to say, in the absence of evidence that BLS eye gels improve patient outcomes over bagging and waiting for ALS, I think it's fine. I prefer to be conservative. And I think the other way to say this is, I think right now we would say our standard of care for ALS is if they're putting in a supraglottic airway, they have continuous capnography with recording. And so unless there's some evidence that withholding this treatment on the BLS level is harming patients, we should hold BLS to the same standard of care.
Thank you. Pam?
Yeah, I mean, I agree with that. So even just to say like offhand, less than a quarter of our cardiac arrests are only going to be a BLS only response or throughout the New York City 911. In terms of like the time that it takes between like BLS and ALS arrival, we're going to be on the matter of, on average, I believe it's going to be about like 5 to 10 minutes. But I think like also like if you go back to like research and everything else, literature, everything that's always been said about cardiac arrest management is like good ventilations. There's never been anything that said that you're going to have any improved outcomes with having a supraglottic airway in place for cardiac arrest patients, even if as long as we have like good ventilations. So I think, just to reiterate exactly like, what Ben said, we're already holding our ALS providers to this level. And I think that a lot of times New York City has actually taken the lead for providing good appropriate safe care for our patients, that we've taken it, and afterwards New York City would be adopting it, similar to what we did for supraglottic airways for our ALS providers, and then also for as well as for like a lot of like our COVID policies and everything else in the past. So I think that we should maintain our high standards in terms of keeping it equal between our providers, especially for something that's going to be new for a lot of these providers that may not have as much education and everything else than the ALS providers, and when we're talking about advanced airway management.
Thank you. Okay, so I think we've had a pretty lively discussion about this. Our options right now, we have a motion on the table, so we can vote on this motion in affirmative or against it. We can table the motion to a place in the future, either to the next REMAC meeting, to the protocol committee, wherever it might be, to discuss it further. But those are our options right now. And the motion on the table is not to remove this, it's just to add the requirement of waveform capnography with monitoring. So I would entertain a motion to table. If I don't hear that, then I think we should vote on the motion as it stands and see what happens. Sure.
You haven't approved this for a region officially yet, so.
Right, but
should we
that's
do
not
that
in the motion.
before?
But that, again, the motion on the table right
Right.
now is to require,
Continuous waveform, something, does that in essence approve it?
Yes, that is, right.
That's what I'm saying.
But has it
I
been
don't know that
approved by
it-
the state
again,
for
it-
BLS?
It means that if we do approve it, meaning we could eventually have another motion to say we don't want to approve it, but the current motion on the table is as it stands. Now, there's been a lot of discussions that maybe we need more discussion before making this decision. In order to do that, we would have to table it to some other time. Or we can vote on it right now and it'll either pass or it won't. That's what we're up to.
So I'd make a motion to table till the next meeting.
Okay, so I think we need a second of that motion and then we vote on that right away. So Bob will vote on that. So now we're gonna have a vote to table this motion to the next REMAC meeting. If that passes, it goes to the next REMAC meeting. We can discuss it at that point and make whatever changes we want before that. Yeah.
You can have discussion on a motion to table.
Just gonna suggest that.
Well, again, protocol can weigh in on whether, or on the protocols, but the motion will go to the next meeting and have to be voted on then. Any other discussion? Nathan? No, the state approved it as of July 1st.
Approved it to allow regions to approve.
Yeah, as I said, the protocol reads,
Right.
place a supraglottic airway and cardiac arrest, parentheses, if regionally approved, close parentheses.
So it gives, the region may approve it if we choose.
Okay, I have a question. So the agencies like Jamaica that are currently doing it, would they still be able to do it?
Pilot.
Right.
The pilot is ending and now it is part of the region.
But
Part
when
of the state.
when's the pilot? I mean, when do they have to stop in the interim?
So there,
I-
is the pilot over?
Pilot is not officially ended yet.
So that you don't have to worry about that discontinuation until.
Okay.
So anybody, right, so currently that they can do it. Okay, all right, so again, guys, let's just be clear. We're right now just talking and the discussion, I'll get to you in a second, John. The discussion is limited to tabling this to the next REMAC meeting. We could discuss what we're gonna do in the interim while we table it, but that's what we're talking about.
Well, I
We're
think
not talking about the protocol as a whole yet.
the interim, I think the pilot is still holding, so we have
Correct.
time.
Yeah.
To.
The pilot isn't changing. Okay.
Do we want to be a requirement?
John, was your question pertaining to this motion to table or just about the pilot in general?
We shared our data with the quality.
Yeah.
Great to share with everybody else who doesn't know what our numbers look like. For more information, I'd be happy to share this and make some questions.
Yeah, so again, the QA committee reports it to the region. Okay. Hearing no more discussion on this motion to table, we're gonna vote on the motion to table and we'll go from there. So I just see it's a hand vote, right? All in favor of tabling this to the next REMAC meeting, please raise your hand. All right, and keep them up for a second. I can't see in the back corner. 1, 2,
Three back here.
3, 4, 5, 6, 7, 8, 9, 10,
Standard.
anybody opposed? 1, 2, 3, 4, 5. Any 6, 7.
Do have one back here.
Any abstentions? 8. 1 abstention. So the motion carries, simple majority, it's not a vote. Okay, so we are now tabling this to the next meeting, which is in September, and we will discuss it further then. That, I would say between now and then, we should probably decide if we want to not approve this in the region, and if we choose to do that, then this will be moved.
Policy statement will also be posted before then as
Good.
well in the state, so that'll be more information.
Right. Okay, we have 2 items of unfinished business and then 1 item of new business, so let's move forward so we can get through it. The STEMI tag report, I believe Pam?
Oh,
okay with that?
Yeah, sure. So from the STEMI tag, I believe, met the end of May, virtually. I think at that time, we reviewed to say that, that the tag's main mission, is to, take a look, review what our current policy is, but then also to be able to, in order with that, as well as like leverage technologies that may be emerging, but to continue the systems of care approach when possibly making any changes to our current STEMI policy. So with that, we will, the STEMI tag is going to be holding an in-person meeting. I think a location as well as a meeting time to be determined, but will be forthcoming. That will invite interventional cardiologists, EM physicians, as well as EMS physicians who are interested in terms of participating to be able to review what are current protocol policies as well as some other current technologies. And to kind of take all of that into account, as well as taking a look at current data that we have that can be used to see if that can actually also change the policies in terms of like what the potential agreements are, what we see in terms of agreements with paramedic, physician, as well as what the monitor is showing in terms of STEMI agreement. So all of this will be taken into account and then will be further discussed at the next STEMI.
Great, thank you. Any questions for Pam? Okay, that letter is being drafted to go out to all these people. The meeting will probably be in September at the new academic year. The other unfinished business is the patient destination tag that we had. So I'm just going to briefly summarize the discussion that happened there. We'll talk about some of the things that came out of it. There is no action items at all. This is just simply the discussion that happened. There was about the implementation in CAD, and Grace, if you have any updates that you can share with us. I know that the 3 closest hospitals has gone live. And I think that, the co-located hospitals is live. Anything else you can add to the information that we have?
That is everything that is live right now. I know we are continuously looking at what other means we should address to correct any other issues, constantly being evaluated. But those things have gone live in CAD. And, again, we still are seeing officers overriding destinations if it does not fall within those parameters.
Just to be clear, it's the up to three closest hospitals if they're within 10 minutes of the city.
Correct. As was described in the original. And what. There was a discussion about, the quality way of these calls. Dr. Kazan was involved in that discussion, Dr. Seda, all five was involved in that discussion. I think that the agreement is that the QA committee of the region is going to review those. Dr. Seda is invited to come to those meetings if he chooses, and if he can, obviously his schedule is busy, to participate in that QA, which will be, therefore, the region will have the same QA and again, it's not going to be a tax on anecdotal cases. These are system-wide review of the data to improve the systems. To look at trends, it's not meant to be pointing fingers or anecdotal stuff. So that we're working at the exact detail of getting the information, but the regional QA committee will begin reviewing those cases and working with Dr. Seda and the fire department. Glenn, do you want to add anything to that? There was a conversation about the definition of medically complex patient. The patient that crews are supposed to be contacting telemetry to a more distant hospital. There is no action items on that at all. As a region, that definition of what is a medically complex patient, I think falls under the purview of this committee. I think it's important that we define it so that we're making it clear to crews when they should be seeking an additional. I mean, the patient says, I need to go to my hospital. Well, again, for these types of things, we want them to know to be asking about that. I don't think they should be asking about that for every patient. That doesn't make sense. So I think that is something we're working on, and the tag will continue to work on that definition. I think those were the things that came out of the discussion. Is there anybody here who would like to add to that discussion or any questions that they would like to send to the tag? I would love to hear. John.
Yeah, so a couple questions for the tag. So
Sure.
One, there is in the OGP a statement that essentially limits medical control. I can read it, but it says, I think medical control should not be used in order to determine destination. It's in the OGP component, not in the medical advisory. And so this goes kind of counter to, I think, prevailing philosophy amongst us regarding the importance of medical control as being a resource for our crews. And this was recently reaffirmed at the CMAC that medical control is a resource, and there's longstanding documentation that transport decisions are both operational and medical.
Right.
And that having access to medical control is part of is kind of a primary function that we're really here to serve as REMAC. It's one of the few things that REMAC actually is here to do.
Correct.
So I would ask that, I have a couple asks of the tag. So one ask of the tag is to see if we can adjudicate that and to see if we can, I think we should make sure, and I've heard that there is a sense of this, that there's no either discipline or threat of discipline for people who are, for field crews who are calling into medical control, asking for help. So I think that's really important. And I think it's a side impact of this policy. So I think it should be addressed.
Okay.
Section 4.2 in the OGP. Thank you. So, I mean, I think we can open up here. Does anyone disagree? I think we all agree with the statement that there should be no discipline or threat of discipline for using medical control. I think we can all agree with that, right?
Yeah, I mean, I think if a field provider has a question, regarding an aspect of that call, whether it's the care or they're not sure about a transportation decision. I mean, medical control is always a resource
Right.
for field providers, and they should be able to call if they need help.
So I would ask the tag.
Hold on, I think Glenn wanted to comment on that.
Yeah, no, I'm just curious because, discipline is not under medical oversight, right? I mean, discipline comes under operations. So I'll ask Grace, are crews getting disciplined, getting CDs and such?
No.
Because that's the discipline. I mean, there are some times when the medics might say, you don't need to call us, but there's no discipline. We don't do discipline. So,
I think-
but by discipline, what do you actually mean?
So I would argue that the kind of the disincentivization of medical control is probably something we should talk about, because I do think that if anything, I'll tell you from in our system, that we actually make an effort to encourage more use of medical control when appropriate. And when appropriate is really like any time where they think it's appropriate. That simple. And so I think that there may be some disincentivization going on around medical control that is a side impact of the policy that I think the tag should look at.
So I agree with that, and
I'm okay with that, but it's not discipline.
No, no,
Right,
I
right.
agree.
But
And
I just want to counter that word discipline. It's not discipline.
Okay. And I hear what you're saying, Ben, 1 second. I think that what would be helpful is if we have these cases that they could be reviewed by the QA committee, not a specific he said, she said, but if there's somebody who feels if any ambulance in the region has a crew that contacts any medical control and feels that they were not able to ask a question, that should definitely come to our QA committee to go to these medical control facilities and ask for some clarification. So I think that instead of saying, well, as a generalization that this is happening, we should get specific cases so that we can definitely review that. But I think that part of our job and in terms of what we're talking about for online medical control is defining or giving the crews better direction on when they should be. Yes, you can seek it for anything, but I think that, like Glenn is saying, if they call and said, you don't need to call medical control for this, that's not really inappropriate to say. Maybe we should be doing a better job of saying, this is the time where you should be calling medical control.
I agree. I think that's fair. So,
And then, okay,
I have a second thing about it.
yes, Art, and then we're gonna go back to John.
Yeah, I just want to say that John's raising a good point.
I agree.
We want to make sure that people can call med, but your point, Joe, is also correct. People need guidance
Correct.
as to when asking for medical control will be helpful. Thank you.
Thank you. All right, let me just go to Ben and then we'll come back to you.
And I mean, I just wouldn't say there's consensus or that we all agree, because I think, there is a large operational component here. And I think that the fire department operationally has said,
Of what? What are we talking about?
calling medical control to request transport decisions, where there's a large operational component of, I think the fire department is saying to the crews, do not call because the patient says, I want to go to this hospital, even if it's an hour away. The fire department, I think, is providing some guidance that, there are certain circumstances where you should call and some where you shouldn't. I agree. In general, we should not discourage people from asking advice from a physician, but there's a large operational component here of, telling crews there's an impact on telemetry to get those phone calls, and any patient who wants to go to any hospital, the answer is not yes, just call telemetry and see if they'll approve.
Correct. And again, like I said, I think we need to clarify and make it clear to our units when they should be calling telemetry, right? By defining what are these medically complex calls that they should really, but at the same time, I think that if a crew feels that they need to call, they should be able to, they should be made clear, listen, this isn't something you need to call in the future, but I don't think anybody should be made to feel bad or told that they can't call. I think that was John's point, but I agree with what you're saying. John, point number 2.
Point number 2, but before I do that, just real quick, because you nailed one really important thing, which is that the absence of inclusion of more medically complicated patients is actually how this got to be, because had they done the positivistic, this is the types of patients we want you to call for, as opposed to don't call. We wouldn't have had this desensitization.
Listen, we could talk about spilled milk. It's not going to help us right now.
Yeah.
I think if we can help define that in a way that is both operationally responsible and medically responsible, that's what we really need to do.
The second point is BEMS 0601, which is the BEMS policy that is actually what empowers agencies to make their own destination decision policies, which is kind of the basis for this, has some specific language regarding what, when it specifically, first of all, advocates for some element of patient choice, but also makes it really clear that when a patient choice can't be adhered to, that the field provider should be documenting the request and why that request shouldn't have been, wasn't adhered to in the PCR. And I do think that we should be encouraging people to follow the existing BEMS policies, which is what has allowed this new change. And so my ask of the tag and my ask of everyone is that I think we should be encouraging folks to document in the PCR. I know we're, again, trying to do it. It's not an easy change because this is a new situation that I think some of our folks are encountering. But we should be adhering to that policy, and I would encourage folks to look at that policy. Michelle, would I encourage you to include it in the minutes? It's
policy.
0601.
So I think that at the next tag meeting, which will be probably the next week or two, we will bring up this policy and it will be discussed as the tag as well.
Thank you.
Any discussion or any questions for John or any more discussion on the tag report? Okay. Hearing none, we're going to move on to our new business. I have one piece of new business. Does anybody else have any new business? Okay, the one piece of new business I have is there is a vacant EMS community physician seat, which is a voting seat on the REMAC. There are two nominees for that seat, Dr. Bob Hoke and Dr. John Vega, who are both here, and I will allow them to say a little bit about themselves. This is a ballot vote. It is for the entire membership of the committee. I have discussed this with the two of them. I'm going to let them speak in a minute, but I just want everybody to be aware of my idea here and what I'd like to do. We are going to vote on this seat. There is going to be obviously somebody with more votes, somebody with less votes. The person with more votes will get the primary seat for this position. The person with less votes will be the alternate. This allows both physicians to be involved, and if there in the future is another primary seat, they would be able to move into that seat if appropriate. I think this increases our involvement, which is really what we want to see. And I think that both are qualified physicians. So either way would be a good thing. But I'm going to allow both of them to say a brief thing about themselves. So I'll start with, because I can see him, Dr. Hoke, and then Dr. Vega, who's behind this pillar. So Bob, if you don't mind. Oh, I can't see either of you. You might want to come in front here so that we can see you. Yes, the light has to turn red. There you go. Now you're good.
Is that the first test?
Yes, first test is you have to speak into the mic.
All right. So hi everyone. My name is Bob Hope. I've been in New York for a while now. I did my residency at Maimonides in Brooklyn. After that, sort of really enjoyed the sort of systems of care pathway and pre-hospital setup of medical care, and went to Emory for my fellowship. In Emory in Atlanta, I was really involved in mostly pre-hospital education. I did a lot of work with the medics and the EMTs there. However, that was also during sort of peak COVID times. So I was involved in vaccination rollout where we had to set up malls and like drive-throughs for people to get vaccinated, and also set up a lot of teaching sessions with different sort of government industries to make sure that everyone sort of knew what was going on in different stages of this sort of pandemic. Now in 2021, I came up back to New York where I got involved with Mount Sinai, where I've served as the Associate Medical Director for EMS and Disaster Preparedness. And since then, you know, I've been involved in a number of different things, but probably my primary, I would say, you know, highlight is that I've developed this annual sort of CME curriculum where we get monthly, we have as many as 150 participants. And we've been doing this for about 3.5 years now on a monthly basis. And we hit every topic to make sure that we're not just sort of focusing on like the sexy topics for medical care, but also we have special guest speakers. I've been involved with the pediatric intensive care units. I've had a number of different people come speak and sort of make sure that we were getting adequate education to all of our pre-hospital providers.
Thank you.
Okay, yeah, let's go. No, that's cool. That's it.
Okay, Dr. Vega, I don't know, I can't see you behind the pillar. Sorry. That microphone has the light on.
My name is John Vega. I'm currently the Associate Medical Director for Pre-Hospital Care at Jamaica Hospital. Did my residency at Kings County in Brooklyn. I graduated 2017. Did a medical simulation fellowship at Morningside St. Luke's, or Morningside West. In 2017 to 18, I focused on EMS communication, IMS handoff, abstract acceptance. Since then, I've been at Jamaica, one more year there. I did Jamaica Hospital the last 7 years. And I've been now attending these meetings for about 2 years or so with REMAC here, spearheading some of the efforts for education for EMS crews. Jamaica Hospital currently serves as one of the busier trauma centers in South Queens, the only primary heart attack center in New York State, and also the only comprehensive stroke center so far in that area in Queens also. So our pre-hospital team see a lot of sick patients. We try and get involved in patient education, and be honored to have a seat in the community chair, get involved, multiple times to see if we need any assistance. It'd be nice to bring that back to our attendings. We don't have any residents in-house. We're all attending driven. So all the impact is directly felt at the clinical bedside for patients. Just be honored to have a seat. Next.
Okay, any questions for either of them?
Not board certified in EMS.
Any questions for Dr. Hope or Dr. Vega?
But normally the CDs go out ahead of time or do that?
It did. Yeah, it was sent out, I think 2 months ago.
Oh, okay.
Yeah.
There you go. I'm also.
Right? That's good. All right, well, thank you. The ballots are gonna be passed around. Just if you could select one, fold it and send it back, that would be great. This is for everybody who sits on the committee, so I see Andrew's back there. It's the primary seat holder only. If your alternate is here, you do not, if your primary is here, you do not. If you're the alternate and your primary is here, you do not fill it out.
Does Kevin vote?
Yeah, you can vote 100%. It's not a position only vote. This is the entire membership. But it has to be it's only the primary, can't be both. They're coming. Yeah, we can tally it here. What's that? Good. That's why I'm trying to keep them both in the loop. Yeah, okay. So guys, if you could not fold it too tight, just kind of.
One fold is
One
fine.
fold only, please. No origami.
No paper airplane.
Okay.
We don't have to.
Can. You know. Wait. Okay,
Oh, yeah.
Pass it down.
so ladies and gentlemen, we are gonna do the tallying of the votes. I have no problem. What's that? You don't need to put a name. What's that? She has ballots and numbers.
There's ID numbers on the ballots. They're numbered ballots.
Doesn't matter.
Again, as long as it's just a primary, it doesn't matter.
Are you confused about the math? Are you trying to stuff the ballot box?
No, that only members voting, anyone in this room could have voted, right?
Okay, so the answer is, guys, come on, I wanna get us out of here. Hello? So the answer is that we're gonna take people on their honor. We're gonna take people on their honor that only the primary member is voting. Okay? We also know how many members should be voting because we have a tally on the ballots. We know how many ballots went out. Okay.
They may not get a ballot.
Okay, that said, Michelle is tabulating the votes. I will entertain a motion to adjourn now. We can leave and we can get this via email if you'd like. Yes. before we have a motion to adjourn, we have an item.
Very quick item. We've all been following our news feeds. We know what's going on in the Middle East. We know that that there's one party that has clearly made a threat to attack U.S. related assets. For those of you who need a refresher on blast injury or nuclear related injuries, the Society of the State of New York has an outstanding set of programs, one of which is entitled Nuclear Blast. All you have to do is go to cme.misny.org and you can find it. I'll send the information to Michelle so that you all have it. But a little refresh at this god awful moment in time might be helpful to us all. Thank you.
Should they have nuclear?
Oh. I'll send.
Yeah.
You have blast.
Yeah, no, I've seen it. It's great.
Okay, have a great summer, everyone. We will, if you stay, we will announce it before everybody leaves, but if you're more than welcome to leave if you don't.
Yeah, he's looking pretty good now, isn't he? At this point, he looks pretty intelligent.
Three.